Hello everyone, this is Dr. Gobind Rai Garg and along with me is Dr. Pooja.
Hello friends.
So we will be trying to discuss a integrated session of physiology and pharmacology, and our topic will be action potential, cardiac action potential mainly. It's all to Dr. Pooja.
So let's discuss first of all the introduction part. We all know that if we talk in terms of cardiac tissue, so let's talk about the cardiac tissue. There are two types of tissue, isn't it? So first is your modified cardiac tissue. We usually call it as nodal tissue. So nodal tissue is going to be there, and then the cardiac muscle, we can call it as cardiomyocyte. Myo means muscle, right? So cardiomyocyte. Now understand, this nodal tissues are the modified cardiac muscle, but they are little different, right? They don't have much of the actin myosin, but they do have gap junctions so that they can quickly transport the ions and electrolytes, and they can carry forward and conduct the impulses. Of course, there are two types of tissue, so action potentials also of two types, right? So let's discuss first of all the nodal tissue. Now, do you tell your heart to contract, relax, now contract, now relax? No, right? It does that automatically. So let's discuss about the nodal tissue. I told you just now that you do not tell your heart, you do not advise your heart all the time to contract right now and relax right now. Thank God. Otherwise, we would not be able to sleep, right? So what happens is, this nodal tissue, thanks to these nodal tissue and the pacemaker, which has the property that is known as autorhythmicity. Right, it is autorhythmicity. That means automatically it produces its own action potential. It's not like the skeletal muscle wherein you have to give the order to the muscle, right? So let's talk about how this autorhythmicity is generated in the pacemaker tissue. Of course, it is going to be the potential which is going to give this property to the nodal tissue. So that's why this property, specifically that property from the RMP of minus 60 to minus 40 millivolt is known as pacemaker potential. This is known as pacemaker potential. Right, this pacemaker is, remember, this is the pacemaker which is going to give the nodal tissue the property of autorhythmicity and make it reach to the threshold, right? And then the action potential will be generated. And usually in the normal healthy adult, we say that it is nothing but your SA node, which will carry forward the impulses to the AV node, bundle of His, bundle branches, and then to the Purkinje fiber. Finally, as soon as it reaches to the Purkinje fibers, those Purkinje fibers then carry forward the signals towards my cardiomyocyte, and they will give the advice, right? I always tell you in the lectures, the muscles are labors. They don't have their own brain, right? They need to be stimulated. So please remember that the Purkinje cells are going to give the contraction or relaxation advice to my cardiomyocyte. So let's see how that is going to take place. First of all, we know that there is a non-stable RMP that is going to be present in the nodal tissue. That is nothing but the pacemaker cells, right? So you know that it is from minus 60 towards minus 40. Now, how this minus 60 potential is reaching automatically to minus 40? That is the role of autorhythmicity, or that is the role of ions. So you have to remember this cat whenever we are going to talk about this autorhythmicity. Now, what is this? This is a funny cat pic, isn't it? So you have to remember this funny cat pic. What is funny cat pic? See over here, funny. That means there are double N. So remember, funny sodium channels or leaky sodium channels. Usually you have to give the action potential, or you have to give the stimulus, then only the depolarization will occur and the sodium channels will open. But over here, there is a modification, isn't it? So what will happen? The sodium channels are going to open up automatically, right? The sodiums are going to leak inside. Then comes this cat. You have to just separate the Ca and T. That means the calcium T channels. Calcium T channels. What is this T? T means transient. We are going to write everything. And this is potassium. P for potassium. So let's write down what is funny cat pick. The first which is channel which is going to help me over the ion, that is going to be your funny or leaky or HCN, that is hyperpolarization activated cyclic nucleotide gated channels. Nobody will ask you the long form of it. Just remember it is hyperpolarization activated sodium channels. Remember, these are leaky sodium channel. You do not require any stimulus for this. Then comes the calcium T channels. T over here means the transient channel. Right? That means for a very short duration, it is going to open up. And the third one is P. P for potassium over here. Usually the potassium channels, I usually tell you that K means kachua, right? It's like a tortoise. It is very, very slow closing channel. But in this modification over here, this potassium will close immediately. So that means immediate, or in books, it is written as early closure. Right? So see over here what is going to happen. Suppose that this is my cardiomyocyte or the nodal tissue, let's say. Now, let's say this is the channel. Now what is going to happen, that first of all, if the potassium, they usually tend to go out, right? But I'm closing the channel as soon as I reach to -60. So potassium will not be able to go outside and potassium will start accumulating inside the cell, will give positivity. What about the sodium and calcium? The sodium and calcium usually is present more outside. When it is going to come inside, positivity will build up. So what is going to happen? Yes, the positivity is going to build up from -60 towards -40. What are the ion channels? Sodium channel, first of all, leaky sodium channel or funny sodium channel, then the calcium T channel, and then comes the potassium early closure. I'll denote it like this. Okay, now we have reached to -40, which is nothing but the threshold level. We always know that as soon as we reach to the threshold level, what happens? The action potential fires up, and that's why it is known as the firing level. Firing level. All right. So what is going to happen? This is going to fire up. Till what time? Till what point? Till infinity? No, only till the spike potential. And what we do at spike, whatever channel is open, close that channel, right? Which channel is open during this depolarization? Remember, in the nodal tissue, it is going to be calcium L channel. L means long acting channel over here. Long acting channel, right? So this long acting channel will be closed. Calcium L channels will be closed. Whatever channel is open, close that channel and open potassium. We know that the repolarization in all of the tissue is going to take place because of this opening of potassium channel. The potassium efflux will start, and we know that as soon as it reaches to -60, immediately these channels are going to close, right? Again, this loop will take place. All right. So this is about here the cardiac nodal tissue action potential.
As far as I have understood, so let me revise what we have discussed this. So nodal tissue are automatic tissues. They automatically contract. So as ma'am said that we don't need to say to the heart that you need to contract. तो हार्ट जो है वो अपने आप धड़कता रहता है. अगर हम ऑर्डर दे पाते तो अच्छी बात होती है, पता नहीं किसके लिए कब धड़क जाता है ना. तो कमिंग बैक, so first of all, for automaticity, what is the important thing is membrane potential should reach the threshold so that automatically it should fire. For that, there must be from -60 to -40. So there are different channels which contribute to this. Regarding pharmacology, the most important channel will be sodium channel. So the sodium channel, whenever any channel open, the ions will move. And when the ions move, current is generated. And when this sodium channel open, the current generated is called as funny current. Funny current. And we all know in physics, we studied the symbol of current is I. And if we write F with this, it becomes funny current, IF. So if we block this funny current, that means if we block the sodium channel, what is going to happen? That this automaticity will decrease. The slope will decrease. So instead of sudden, it will become like this. So for reaching the same threshold potential, it will require longer time. That means the heart rate will decrease. So that means if we block the funny current, the heart rate is going to decrease. So any drug doing so is called as bradycardic agent. So this drug is called as bradycardic agent. And if we see, the name of the drug is Eva Brady. The name of the drug is ivabradine. So everything is written in the name of the drug itself. The name says it is a bradycardic agent. It acts by blocking the IF, that means funny-cry, and the main side effect of this is effect on visual acuity. So this drug causes photopsia. So there will be flashes of light on the eye, that is called as photopsia. One last thing, why ivabradine is called as bradycardic agent, but the other drugs, beta blockers, remember there are metoprolol, propranolol, many drugs which are causing bradycardia, but they are not called bradycardic agent, but only this is called bradycardic agent. The reason is beta blocker will decrease all three properties of heart. That means they will decrease heart rate, they will decrease AV conduction, as well as they will decrease contractility. Whereas ivabradine will decrease only the heart rate. That's why it is called as bradycardic agent. And it is approved for two main uses. It is used in angina and also in congestive heart failure. Okay? So that is all regarding pharmacology from the nodal action potential.
Now, if we talk about, I want to add about the sympathetic and parasympathetic. How the sympathetic and parasympathetic is going to act on this heart rate is, we all know that as soon as the sympathetic system activates, right, as the stress comes, as the exam comes, as your crush come in front of you, what is going to happen to your heart? Your heart will start doing duk, 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 right? That means the heart rate will increase. How this is going to happen? See, if I draw a simple diagram of it, so it will look something like this, right? First beat, second beat, like that. But whenever the sympathetic system activates, the ionic movement is going to increase like this. So it will take lesser time to reach to the threshold or firing level, right? And here you go. What is going to happen if you reach early there? So see over here, instead of 2 heartbeats, in the same time, you're going to have 3 heartbeats, right? So that is about the sympathetic system, that when the sympathetic system activates, that's how your heart is going to work. And when we talk in terms of parasympathetic system, as Sir said, that the same thing is going to happen. So see over here, it is going to take more time. And again, when you activate parasympathetic system, it will take more time to give those 2 beats, right? So it is about the sympathetic and parasympathetic also.
So from this, I remembered one question which was asked. So basically, this phase which is spontaneously, it is going upward. This is called as spontaneous diastolic depolarization or phase 4 depolarization. Remember, in the nodal tissues, there are no phase 1 or 2. It is directly phase 4. So phase 4 depolarization which is happening. So acetylcholine or parasympathetic system, it is going to decrease the slope of this. Whereas sympathetic system, it is like adrenaline, it is going to increase the slope of this. So that was the question asked, how acetylcholine cause bradycardia. So answer is, it decreases the slope of phase 4 depolarization, and that's why more time will be taken. So heart rate decreases.
So as I said, that will be no phase 1 and phase 2. For that, you should know what is the phase 1, phase 2 in the cardiac muscle. So let's see, once our Purkinje cells are activated, how this is going to take place. The action potential in the cardiac muscle cells now, right? So cardiomyocyte. Let's see in the action potential in the cardiomyocyte. So first thing first, we always start from the RMP. What is the RMP of the heart? That is nothing but the minus 90 MV. That is the RMP. And remember that the RMP is always and always phase 4. It is not phase 0. It is not phase 1. It is always phase 4. As soon as the Purkinje cells are going to stimulate my cardiac muscle cells, what is going to happen? Again, the sodium channels are going to open up. Sodium channels are going to open up. Of course, the sodium is more in the ECF. As soon as it is going to open up, it is going to cause the sodium influx. Till what point? Again, till the spike potential. And we know that as soon as we reach to the spike potential, we always do 2 things, right? What are the 2 things that we are going to do? First thing is, whatever channel is open, close that channel. So what channel is open here? Sodium channel was open. So close that channel and open potassium. Open potassium. Now remember, there are going to be 2 types of potassium channels which are going to help us out here. So first phase is the potassium channel which is going to open up, right? So I'll just change the color over here. So potassium channels, they are going to open up. But what happens? Again, it's a heart. There must be something different than the nerve tissue. Otherwise, the Bollywood, Hollywood wouldn't have given so much of the importance, right? So what is different? As soon as the potassium channels are going to open up, there is one more thing which is going to take place, that yes, the potassium is going outside, but the calcium channels are also going to open up. Again, these are going to be calcium L channels. All right. Now, the channels which opened in this small phase, this small phase is the repolarization phase. The first repolarization, the early repolarization, is for shorter duration. So these channels which are going to open up first for the shorter duration, they are known as transient opening channels. Transient opening channels, right? And the potassium channels are very, very stubborn. Unless and until they make the potential to reach to the RMP, they are not going to close, right? But that is not the case in case of calcium. Calcium is not that stubborn. It is going to close after some time over here. So calcium channel is going to close. What was happening in this phase particularly? Look at this phase. What is happening? One arrow is going out. That means potassium is going out. Positively charged ion going outside, but at the same time, one positively charged ion coming inside the cell. So they're counterbalancing each other. And that's why my potential in the cardiac muscle cell is not going to change. And this phase is giving us the flat line in the voltmeter. So I can say this phase as plateau phase, right? So see over here, this is known as plateau, right? It sounds like 2, right? So plateau has phase 2. This is the phase 2. Plateau is phase 2. And please remember that in this plateau phase, 2 ionic movements are going to occur. That is, first is potassium efflux and calcium influx. All right. So 2, 2, 2. Please remember phase 2, plateau, and the 2 ions are going to move. But we know that the calcium channel is going to close very, very soon. But the potassium continues to go out unless and until we reach to the RMP back again, right? So we are going to reach to the RMP. What comes after 2? Of course, 3. We know that, right? Over here, only and only potassium efflux takes place. And again, we are going to reach to minus 90. After 3, what comes? 4, right? And before 2, what comes? 1, right? So this is phase 1. Now, there is one phase we have left over here, that is sodium influx. Please remember, all of the, you can say, the phases, they are either causing the repolarization or plateau phase. This is the only phase, the first phase, that is sodium influx phase, is the only phase which is going towards positivity, and this phase is nothing but phase 0. This is phase 0. And as sir already told you that there are not going to be phase 1 and phase 2, which are going to be absent in the nodal tissue. All right. So phase 1, first 2 absent, but they are going to be present in the cardiomyocyte. All right.
So again, let's quickly revise what we have studied. So we have studied, we have different phases in the cardiomyocyte action potential. So they are phase 4, which is the resting phase. Then we have phase 0, phase 1 to 3, and phase 4. So in simple terms, phase 0, that means opening of sodium channel causes depolarization, and phase 1 to 3, potassium channel is open throughout. In between, calcium cause obstruction, but main it is potassium, so it is causing repolarization. We know sodium cause depolarization and potassium cause repolarization. We are studying since nursery this thing. Okay? So now we will be discussing what will be the effect of different drugs on this action potential. So if I make this action potential again, this is the action potential. So if we block the sodium channels, we know sodium channel open in which phase? Phase 0. So when we block the sodium channel, it will take longer time to cause same depolarization. So effect of sodium channel blockers will be this. So they will take longer time to cause depolarization. So simply this arrow is the action of sodium channel blockers, and sodium channel blockers are classified as class 1 anti-arrhythmic drugs. Class 1 anti-arrhythmic drugs are sodium channel blockers, and they will decrease the slope of which phase? It is phase 0. So they will decrease the slope of phase 0. And this is what is written in your books as class 1 drugs, they decrease the dV by dt of phase 0. This dV by dt is nothing but formula of slope. So they will decrease the slope. Okay. Then Class 1 drugs or sodium channel blockers are further of three types. They are of three types: 1A, 1B, and 1C. Now, on which basis we classify them into A, B, and C? That is on the basis of what they do to potassium channels. Remember, all of them open sodium channel, that's why they are 1. Then A, B, C, what they do to potassium, and obviously three things are possible. One, the drug may block potassium. Second, the drug may open potassium. And the third, drug may have no effect on potassium. So 1A are sodium blocker and potassium blocker. 1B are sodium blocker but potassium opener. And 1C are only sodium blocker, no effect on potassium. Now, effect on action potential is easy to understand. We know that 1A are potassium blocker. And we know potassium is causing repolarization. We discussed if we block sodium channel, it take longer time to cause depolarization. Potassium is causing repolarization. If we block, it will take longer time to cause repolarization. So the effect of potassium channel blocker, that means 1A drug will be like this. It will take longer time to cause repolarization. And this total time from here to here, this is called as action potential duration. So how long the action potential lasts? So potassium channel blocker will increase the APD. So potassium channel blocker, so 1A drugs, they will increase the action potential duration. The others are automatic. So 1B, they are opening, so they will make it faster. So this will be 1B drugs. They will make it faster. So 1B drug. And 1C have no effect on potassium. So no effect on action potential. So 1C drug will be having no effect on action potential duration. And you can remember that very easily. So this is the baseline graph we know. And A means after. If the graph comes after the baseline, it is 1A drug. B means before. If it comes before the baseline, it will be 1B drug. And C means constant. If it remain at that point, it is 1C. So it is easy to remember: A after, B before, and C constant. Now, what is last important thing? You will ask that action potential is consisting of two things. One is depolarization, second is repolarization. And we told that all the three drugs are increasing the depolarization time. Then why don't all sodium channel blockers increase the action potential duration? We said that only potassium channel blockers will increase APD, whereas the drug which is only sodium blocker will not increase APD. So it's a simple logic that suppose the total action potential duration is 800 millisecond, or we can say 0.8 millisecond. Out of that, the sodium channel opening, that means phase 0, it consists of only 1 to 2 milliseconds. Whereas potassium channel is taking long time. I may not be exact, but approximate. So potassium channel opening, that means repolarization phase taking a plenty of time, 99% or more of the time. So if we make this 1 millisecond into 2 or 3 or 4 milliseconds even, then the total action potential will become 802 or 3. So 800 and 802 will not be much different. We cannot appreciate. So action potential duration, we say, do not depend upon depolarization. But repolarization phases of around 790, 798, 799 milliseconds. So if we prolong this to 1200 milliseconds, it will be visible. Clear? So that's why the drugs which block the potassium channel, they change the action potential duration. Okay. Now, the last thing to understand about these drugs, this action potential, if we see in the ECG, we have P wave, then we have QRS wave, then we have T wave. We know P wave signify atrial depolarization, QRS is ventricular depolarization, and T wave is ventricular repolarization. Now the question is, we said atrial depolarization, ventricular repolarization. Where does atrial repolarization go? क्या atrium repolarized होता ही नहीं है? Obviously होता है, but atrial repolarization is behind the QRS interval. We are not able to see in the ECG. So whatever we are not able to see, leave that. But in ventricle, we can see both. So if we start from Q, ventricular depolarization start. QRS is ventricular depolarization, T is ventricular repolarization. So if we end at the end of T, so that means from start of Q to end of T, this time is called as QT interval. So QT interval, what does it signify? Depolarization plus repolarization. The same thing in action potential is told by depolarization plus repolarization. So it is APD. So what we can safely say, APD of the ventricle fiber is equal to QT interval in the ECG. So that means if any drug increase action potential duration, it is going to increase QT interval. If it decrease action potential duration, it is going to decrease QT interval. So which anti-arrhythmic class can increase QT interval? Yes, it is class 1A. So class 1A drugs, they increase action potential duration. So in the ECG, they will show increase in QT interval. And when QT interval increases very much, then an arrhythmia can occur, which is known as torsades de pointes, which is also known as polymorphic ventricular tachycardia. Now, this is the question asked, which drugs cause torsades de pointes or prolonged QT interval? And some of the drugs which have been banned around 15-20 years ago, still the examiner is mad about them, still ask the question on them, that they cause QT prolongation. So what are those drugs? As we have shown in the picture in the beginning, there was a cat, and we know cat is cute. So the cat drugs, they are cute, means they cause QT prolongation. So cat drugs cause QT prolongation. So these are cisapride, estamizole, and terfenadine. So these all have been banned. The reason was same, that they were causing QT prolongation. So all cute people should be banned. Okay, so cute drugs cause QT prolongation. Now, lastly, the drugs which are present in these three categories, 1A, 1B, and 1C. The drugs in 1A category are quinidine and procainamide. 1B drugs are lignocaine, tokenide, phenytoin. 1C drugs are encainide and flecainide. So how to remember these drugs? Again, easy to remember. Remember, class 1A drugs start with A, and they are A category people. A category people means hi-fi people. So who are hi-fi people? These are queen and prince. So queen and prince are hi-fi people. They are 1A category. Then 1B category. So they are B category people. That means who are there to serve A category people, जो राजा की सेवा करने के लिए बने हैं. So like lignocaine legs दबाता है राजा की, लेग दबाने के लिए बना है. फेनिटोइन राजा को फैन देता है. रिमेंबर, एसी का जमाना तो था नहीं राजा के टाइम, फैन ही देना पड़ता था. और टोकेनाइड राजा को टोपी पहनाता है, क्राउन पहनाता है. सो दीज आर 1B category. So all remaining will be 1C category. Okay? Now out of the three, which will cause QT prolongation? So obviously it is A category people. जो हाई-फाई लोग हैं वही तो क्यूट होंगे, हम जैसे लोग थोड़ी होंगे. Okay? तो quinidine and procainamide, they cause QT prolongation. Okay? So that's all about pharmacology in this action potential. So that's all. So I hope you must have liked this lecture, and do give your comments if you like this lecture. So we'll try to make more such lectures for you.
Yes, and if you have such topics in your mind, then do suggest us also. We'll definitely try to make the video on it. Thank you very much.
Thank you very much.